So thank you very much for giving me time on your Saturday afternoon. Here in England, it's very sunny, bright, and hopefully it's going to be good where you are as well. So today I'm going to talk about minimally invasive techniques in posterior maxilla, which is an interesting topic because maxilla is an area which is always challenging and which is always difficult to treat for implants. So I will tell you the techniques which are less invasive, which are better for your patients. Because to me, if the patient has got minimally invasive techniques or minimal invasion for the surgery, then that is the best treatment plan for the patient. And imagine, if you are a patient, what would you like? You will definitely like to have minimal invasion. So I work in England. I've got a practice in Oxford and Bristol as well, and I go to different practices placing implants. I am a dental ambassador for South West England for Royal College of Surgeons, Edinburgh, and I'm an honorary clinical teaching fellow for University College London, Eastman Dental Institute. So I am associated with them as well. So this is how important we are. Yes, when you had a look at this picture, at the first instance, you noticed the missing tooth or a gap in the mouth. You didn't notice the missing eyebrow of that gentleman. Smile is important, and this actually tells you what kind of person you are. And because we deal with smile, we make the smile better. That is where we come in, and that is where we are in. That's why we are important, because we deal with people and improve their smile. Is it good? Are you listening and hearing okay? And the slides are okay as well, hopefully. Okay, that's good. So we'll move on. But if we are important, that society actually considers us important, but it actually gives us a huge responsibility as well, so that we can fulfill their wishes. We can fulfill what they actually came in for. And that responsibility is not only giving them a beautiful smile, that responsibility is giving them the smile that they deserve in a way that they deserve. You cannot give them smile. It's not your treatment plan. It's the treatment plan that you have to go with your patients. It's the treatment plan which will be with your patients. So it's time to plan. I think this is the most important slide of my webinar. If you plan it well, you will do it well. I think most of the time, you need to spend time on planning. Spend time listening to your patients. Spend time to make the right diagnosis. Spend time to get all the information from your patients. And once you've got all the information, analysis of that information and developing a treatment plan is your job. And then discussing it with your patient and giving the best possible treatment outcome. That's what you need to deliver. Yes, execution can be a problem if you do not have the proper skills. If you lack skills, then execution or implementation can be a problem of that plan. But most of us are very good skillfully. So we are excellent when it comes to doing something or performing dentistry. But I think we take the planning a bit too lenient. So, if we spend time on planning, then this is the key. this is what we will benefit the patient the most. So please spend your time on planning the case properly, and then execution should be okay. In England, what I would say, we do what is called as covert dentistry. Litigation and the regulations in England are so huge that we sometimes get scared. We sometimes get afraid. But is this the right thing to do? What's the limit for us where we can actually push our limits? Have a look on the slide. As you can see, that there are people who are specializing in suing the medical or dental professionals who treat patients on bisphosphonate. So if you treat a patient on bisphosphonate, there is a specific lawyer who will have the expertise to sue you, who can pick the mistakes in your notes, who can actually bring a lawsuit against you. So this is the kind of challenge we are dealing with. This is the kind of limit we are dealing with. And I think it's going to get worse day by day, because there is more awareness in the public for what we do. There's more awareness in the public that we make a lot of money. Yes. And as lawyers, they can get to sue us easily. But if we look at ourselves as well, how many of us actually are confident in dealing patients with bisphosphonate? How many of us are confident in dealing patients with other medications? Like, are we confident enough of the medications which can cause MRO-NJ? Do we know about those medications? Do we know what those medications do? So if the answer to these questions is no, or the answer to this question is I'm confused, then we are weak. Then that's where we need to upgrade our skills. We need to upgrade ourselves. Because if as a clinician, or if as a dentist or a doctor, we are treating a patient and we are confused, that's not good for a patient. That's a no-go area. We should be very sure, we should be very certain that what is in front of us and what's the challenge which is in front of us. So keep asking yourselves, are you confident in treating these medically complex patients we are seeing at the moment? Which are the patients they're going to have implants? Which are the patients they are going to have, you can do implants without any, and being afraid of, or without not spoiling your night's sleep. Now there's an increasing trend, and this trend of immediate placement, taking the tooth out and putting the implant in, is increasing day by day, and it is quite appealing to the patients as well, because the patient gets the implant straight away. The tooth is out, the implant goes in, and that's the magic. It sells very well, it's convenient for yourself as well, and it's convenient for your patients as well. They don't have to come back. As treating dentist, you are treating the patient in less time, and they're going to see you less. So it's very appealing. It's selling. It's a good sell as well. But if we look at the criteria for immediate placement, Here's a slide in front of you, which has got the criteria for immediate placement. Like, you should be sure that your implant you're going to place is going to be primary stable. The bone quality is good where you're placing implant. You have the presence of socket walls. You have bone beyond the apex of the tooth. You need to keep in mind that maxillary incisors and canines are curvilinear. Have a look at the implant bone interface. How much of implant is actually engaging in bone? Your surrounding anatomy. You've taken a 7 out, which has got a granuloma, very close to ID nerve now. How are you going to place implant beyond the apex of that 7 which had granuloma? And how are you going to keep the ID nerve safe? So that's the question you need to ask yourself. Atraumatic surgical technique, how confident are you to take the tooth out atraumatically? We do quite a lot of mentoring as well all over the world. So I get pictures sent to me on WhatsApp, Viber. Oh, can I place an implant in this tooth now? I've taken the tooth out now. And believe you me, looking at the extraction, all the walls are gone. And my question to myself is, where would you want to place that implant in here now? So you should be confident enough in extractions. Your surgical technique should be atraumatic, and atraumatic means atraumatic. It's not that the patient has blood less, so it's atraumatic. Presence of infection. Was there an infection present? And would you want to place an implant in an infected site? Implant design as well. What kind of implant you are placing in and what kind of design you have got in that, which is going to go in that area. So if it's a very strict criteria, how many of us actually who are selling immediate implant placement, or who want to do immediate implant placement, or who are keen to tell their patients or promise their patients that we're going to place an implant immediately? How many of us actually can think in their head and see that how many cases do fulfill this criteria? I would say not many. In my practice, at least, not many patients actually fulfill this criteria for immediate placements. So would I do immediate placements? No. If this criteria is not being met, then I am not going to place an implant immediately. Because what I want is predictability. What I want is that I should not be bothered by the lawyers. I should not be bothered by the patients saying, calling me in the middle of the day, oh, the implant you've placed is loose now. So predictability, take your time. What's the rush? So have a look at all this criteria and see how many of us actually fulfill this criteria for immediate implant placement cases. If this criteria is not met, then my advice is do not place implant immediately. Sometimes I get x-rays sent to me on WhatsApp saying, oh, I'm going to take this tooth out and place an implant immediately. Shall I? By looking at the slide, you can tell me now what should be my answer. Professor Gilberto, Naples, May 2006. Immediate loading is another interesting criteria, interesting topic as well. So can we place the implant immediately, straight away, and then put a crown on top of it straight away? Yes, it sells very well. It's very appealing to your patients, and that's the ideal treatment you can offer to your patients. That's the ideal treatment you can actually promise your patients. That you will come in with a broken tooth, I'll take the tooth out, I'll place an implant in, and I'm going to put a crown on in straight away, and you go out with the tooth in there. You come in with a broken tooth, you go on with an implant and a crown and a tooth on top of it. Problem solved. But there are some factors to consider. Keeping in mind the last slide, which tells you the criteria for immediate placement, and keeping this slide in mind, the criteria for immediate loading. Be honest and ask these questions from yourself. How many of our patients actually fulfill this criteria? The implant you're going to place should have an insertion torque more than 35 Newton centimeter or 35 Newton centimeter. Implant length 10 millimeter or greater. Thread design 3.5 millimeter. A thread design, it should have a thread design which should be 3.5 millimeter or greater. The patient should not have heavy occlusion. No bruxis. You cannot place an implant immediately and load it on top. Primary stability, it should be primary stable. The bone quality should be good. So how much of us have got good quality of bone when we are placing implants, especially in posterior maxilla, the kind of area we're talking about today? Yes, mandible, you can have good bone quality, but in posterior mandible, be careful that it's D1 bone. So D1 bone means, sometimes it's D1 bone, and D1 bone means less blood supply. So the good bone quality is in the middle, not on the extreme sides. Good crown root ratio, how much longer implant you're placing and how much longer your crown is. So you need to keep that in mind in order to immediately load your implant. Is the patient able to achieve or maintain good hygiene? So that is another thing you need to consider. You need to think about it so that you can decide with the patient about immediate loading. So keeping in mind the slide which I showed you just now and this slide, how many of us actually fulfill this criteria of placement and loading? There was just an eye-opener for all of us, you see, that if you just list those criteria, there are very less cases left which will actually fulfill those criteria. I was involved in some systemic reviews as well. So dental implants have got high success rate even in cleft lip and palate patients. So blaming the implants may not be the right approach in my eyes. They are successful in cleft lip and palate patients where the bone quality quantity is going to be less. So by no means our implants should fail in our normal patients. If they work well in cleft lip and cleft palate patients, then they should work well in normal patients. So this implant is the brand is not right, or the brand is not of I don't like the brand. I think before blaming the implants, I think we should look into our skills, our planning, and what did we do. Yes, implant placement in sinus augmentation while doing the sinus augmentation is a stable procedure as well, and there's no doubt about that as well. So if you want to place an implant and do the sinus augmentation, again, fulfilling the criteria, it should work as well. So these kind of things tell us that there are less problems with implants. There may be more problems with us. So we need to take a step back and think again. Now have a look at the healing time and the procedure of healing after tooth extraction. After tooth extraction, the healing starts with the granulation stage. Then there is growth of blood vessels and the nerves as well. New bone formation happens, bone growth happens, and then bone reorganization. So if you look at these extraction site healing pattern, you can configure in your head what kind of time is better for you to place implants. Have a look at the healing pattern around implants. So remember the last slide, we had granulation tissue formation. Around implants, there is no granulation tissue formation. So there is vascular sprouting stage, early bone formation, bone growth stage, and bone maturation stage. So that's the difference between the extraction site healing and the healing around our implants. So that will give you an idea what is the right time to place implants and what do we actually expect from the bone around our implants which we've placed. Now, posterior maxilla, let's get to the area which we are going to be talking about today. Posterior maxilla has got the biggest challenge in posterior maxilla is, I would say, sinus. The other challenge is, of course, bone quality, but sinus is the bigger challenge than bone quality. To deal with the sinus, there are different procedures what we can do to elevate the sinus membrane and put bone graft in the sinus. Sinus floor elevation, sinus lift, maxillary sinus augmentation, antral sinus lift, or sinus bone graft, these are all the same procedures. So they can be called by different names. So a bit about maxillary sinus. It's also called the antrum of highball. It's the largest paranasal sinus in the head. Interestingly, it is size of pea at birth, and as we grow in age, the maxillary sinus actually gets bigger, and we have seen sinuses, huge sinuses in patients who are old and who have been edentulous for ages. So it actually differs in size. You need to be careful about that. Most development of maxillary sinus happens with the permanent dentition, and there are no major blood vessels in the sinus. Having said that, the blood supply of the maxillary sinus is through maxillary artery, which is posterior superior artery, and infraorbital palatine arteries. But there can be anastomosis, which is end-osseous anastomosis between posterior superior alveolar artery and infraorbital artery. And that is the biggest challenge, I would say, in making the lateral window for our lateral sinus lift. This anastomosis is 5 to 20 millimeter from the ridge. So in the height of the ridge, it's about 5 to 20 millimeter. So it's a huge range. It's 20 millimeter from the crest of the ridge, which means that we need to be careful in making that window. If we have got drill in our hand, then we can damage this blood vessel. And the good thing is that it atrophies with age. So as the age advances, it actually atrophies. Less chances for patients who are old to have this artery being huge or very big. So we all are aware of the crestal approach or internal sinus lift approach. As in the picture, it shows that you stop below the floor of the sinus with your drill, then you take your osteotomes, fracture the floor of the sinus, and put the bone augmentation products or bone graft, whatever you want to use, and then you literally place your implant. As compared to the internal sinus lift, the external sinus lift, you need to make a lateral window and you lift the membrane of the sinus, put your graft in and put the implant in. So that's the difference between your internal and external sinus lift. It's just creating the space in the sinus, bone in the sinus, for your implant to be in bone. Coming back to the artery we talked about, if you look closely, that's the posterior superior alveolar artery, and that's the kind of vessel we are talking about. That's the kind of vessel we are talking about. So that's a cadaveric specimen. We do run courses in London, and you will have a website the email address in the end, so you can contact us if you want to avail these courses. So this is one of the course we demonstrated the vessel which you should be careful about by making the lateral window approach. So you can see it's quite evident. It's quite clear the vessel is present. The moment you're going to put the drill on it, it's going to rupture, and that is going to be difficult to control the bleeding. Now, before making a window, can we actually see that vessel? Or can we actually have a clue where the vessel is? The answer is yes. CBCT, if you look at the CBCT very carefully, then you can see the two holes that are shown, the two black areas that are shown in here is the vessel. So you can see that vessel in CBCT if you know how to read your CBCT properly. So you can be aware of this vessel before actually lifting the flap. So you can see that vessel and avoid that vessel, or you can get yourself prepared to deal with the bleeding which is going to be caused by this vessel. So that's the reference. It is found within 16 millimeter of the ridge in 20% of the cases. 20% of the cases make every 5th case. So you can see how frequent they can be. So this is the procedure we're showing you, that where we have dealt with that vessel and we have ligated it. So that's the lateral window. You can see that's the lateral window which has been created, and that's the vessel which is separated and taken care of while doing the window. Now there are different ways of making windows, and we're going to touch that briefly later during this presentation. But I use piezo quite a lot, and that is I think is a very, very good way of developing the lateral window and minimizing the damage to the soft tissues. So you can see we made the lateral window, and then after separating the vessel, we are ligating it. So we ligate it from both sides, put a stitch across on both sides, and then we cut the vessel, and that's how the bleeding is controlled and the hemostasis is achieved when you encounter this vessel. So when we deal with cases where you have insufficient bone height in posterior maxilla, there are ways you can deal with it. Lateral window, sorry, I'm keep checking my mobile so I can see that whether you guys are seeing properly or hearing properly. I don't want to just keep on going where you're not hearing or seeing anything. So, okay, so insufficient bone height is the challenge we're going to deal with in posterior maxilla. Lateral window, if the residual bone height is 1 to 3, then you will be going towards lateral window. The residual bone width, 4 millimeter, is fine. And the maximum height you're going to gain with lateral window is 10 millimeters. Although, having said that, you have got the facility of short implants nowadays. So you can use short implants rather than going and being greedy for 12 or 10 millimeter implant. You can go for a shorter implant and maybe get away with crestal approach. So that's the decisions you have to make when you are doing the planning for these cases. Traditional Summers lift, which is internal approach or crestal approach, if the residual bone height is about 4 millimeter, more than 4 millimeter, then you should go for the crestal approach. And the maximum gain height in the bone is about 2 to 3 millimeters. We have pushed this 4 millimeter limit to 3 millimeter as well in our cases. So that's one of the patient I will show you. We have done a lateral window approach on this patient, and the method we have used in this case is the DAS kit. it's a very good kit. I'll show you the burrs in a bit. It's a very good kit, and it will allow you to have a minimally invasive lateral sinus approach for your patients. So that's the case. You can see this is a pre-op. You can see the upper left 6 is missing, and we're going to place an implant in there. So that's the CBCT scan, showing all the views. You can see how we have done the markings on the CT scan and orientate ourselves. You can see the quality of the bone in this picture. Actually, you can see it's literally the mucosa which is blocking that hole from inside the sinus. So the bone quality is not good at all. The bone is patchy, and where the bone is present, it is thin, and in some areas the bone is not present at all. It's a hole in the bone. So these kind of cases you will see should be dealt with open or lateral window approach. So that's the pre-op CBCT, and that will tell you how much of bone height we are dealing with. The bone height is really, really very minimal. So when we raise the flap, you can see we raise the flap with 2 releasing incisions so that we can have proper exposure of the lateral wall of the sinus. And I want to spend some time on this slide actually. These are the burrs of the dasket I was talking about on your lower right hand corner. So these are the 2 burrs which my cursor is on now. These are the 2 burrs which are used for crestal approach. So these have got marking of 3.3. These have got the diameter of 3.3, and this is diameter of 3.7. So you've got 2 burrs for crestal approach, 3.3 and 3.7, and then you have got the markings on the burr which will tell you how much deep you want to go. So these are the markings which are 2, 4, 6, 8, 10. So this will tell you how deep you want to go. And that's with these burrs you can make the crestal, your osteotomy in the crestal approach, and then later on place them. The beauty of these burrs is that they have got a very nice shape. They're round. They will be minimally damaging to the sinus membrane. The other beauty is that they have got the hydraulic system in them as well, which means they have got internal irrigation, and the water which is being used comes out through the shaft in from this hole and sprinkles on top of this burr, which means with the hydraulic pressure, the sinus lining is pushed by itself. So it works both ways. First of all, it will not damage the membrane with this shape. And secondly, with the hydraulic pressure, it will push the membrane up. So once you've gone with the membrane, then you can use this burr. This is literally a water sprinkler. You must have seen the water sprinkler in the garden, which actually revolves like that and sprinkle water in all aspects or all directions. This literally works like that. So once you've got the membrane in front of you, you use this burr. This will act as a sprinkler, put the water from all directions, and will help you in lifting the membrane. So these are the burrs that can be used for crestal approach, although this burr can be used for lateral window as well. Now these are the burrs that will be used for lateral window approach. You can see that this burr is smaller than this burr. So this burr has got a diameter of 6 millimeter, and that burr has got a diameter of 8 millimeter. So if you want a window which is 6 millimeter, then you will use the smaller burr. And if you want a window which is 8 millimeter, then you use a bigger burr. So that will give you a very precise window which is 6 or 8 millimeter. You don't have to make those big lateral windows anymore with this system. And with this tray find, you can use literally create a lid of lateral window and take it out, and then you will see the membrane in front of you. This tray find has got 2 markings. So you can see the top marking, the top band is 1.5 millimeter from the end, and the second band is 3 millimeter. So if with this, your CT scan, you can actually judge what's the thickness of your lateral window. If it is 1 to 1.5 millimeter, then you use the tray find till the first mark. If the thickness of lateral window is 3 millimeter, then you use the tray find to the second mark. So very cleverly designed. So this is the system I've used for this case. So you can see I'm using the lateral window burr to create the diamond burr to actually create the lateral window. And when you create this window, you will see this type of grayish tinge. That is where you should start getting careful, be patient. That is where your membrane is very close now. And you can see it more clearly now. So you can see that membrane, this is the window we have created, and that's the membrane just showing. With this, these instruments are also enclosed in the same kit. So with this instrument, you can just gently push your membrane, fracture the remaining part of your very thin lateral wall now, and you can actually start pushing your membrane. Some more instruments, you can literally lift the membrane off the floor with these blunt instruments. And when you have to actually make sure that you have lifted the membrane from all sides, the floor, the mesial, and the distal side as well. So once you've lifted that membrane, you can see the membrane has been lifted. That's the membrane, and that's the area we have created very nicely. And that, look at the window. It's literally 8 millimeters window. Once you've created that gap, you place your bone graft in, and that is we didn't place the implant in this patient because the bone height was not going to give us primary stability. So we just grafted this patient. So the graft is in. You put the membrane, a GBR membrane on top, and that's the closure. So in a minimally invasive way, you can do lateral sinus approach or lateral window approach as well. You don't have to make those big lateral windows anymore. Here's another pre-op immediate post-op X-ray. You can see this is the graft which has been placed, and that's the thickness we have been gained. So that is immediate post-op X-ray. Here's another patient. You can see we're dealing with a less height of bone in posterior maxilla again. That's the measurements we have done on this picture, and that's the pre-op for this patient. Again, the same approach. You've raised the flap with this burr. We have just created the ditch in the lateral wall of the sinus. With instruments, you are just shifting or lifting the membrane and using the sprinkler effect and smoothing any sharp edges in your window. So these burrs are very good to smooth any sharp edges on the window. And mind you, I've already told you that you will have the water through them as well. So they will create the hydraulic effect as well to lift the membrane. And then you can see that we are dealing with the membrane, lifting the membrane from all sides. Bone graft, and then that's the closure. Now that is the lateral window approach. I just want to mention over here that in fact, your planning for implants starts before taking your tooth out. You don't have to worry about less bone if you have had the tooth in there. So for example, have a look at this tooth, upper 6, which is broken buccopalatally. You can see there's a fracture line going in, and buccopalatally there is a fracture. So this tooth has got poor prognosis. This tooth is going to come out. I want you to concentrate on this height of the sinus. This sinus height is about 4 millimeters, and when you take the 6 out, the bone resorption is going to happen in about 6 months to 1 year. This 4 millimeter will become 2 millimeter. And when it becomes 2 millimeter, we are all thinking about lateral window approaches. My plea to you is that why don't you actually plan and act at this time and do not lose the 4 millimeter. That's going to be the key in all the planning. So this is the minimally invasive way you can treat patients in posterior maxilla. Rather than thinking, sit 1 year down the line, thinking about lateral window, you can actually utilize this 4 millimeter. I know we've got a great surgeon hidden in us, all of us, but it's time to actually let the surgeon sleep and worry or care about our patients so that they can have the problem resolved in a minimally invasive way. So have a look at this case. This we did the extraction for number 6. So we raised, gave 2 releasing incisions, took the tooth out. You can see the granulation tissue still attached to the tooth because of the fracture. And that is where we're going to use the osteotome. So these are the 2 roots. That's the palatal root, and that's the intraradicular bone, which is being pushed in by the osteotome. So that's mesiobuccal, that's distobuccal, that's palatal, and that's the A hole we have created by pushing the intraradicular bone in. The same anesthesia, the same procedure of extraction. And that's the bone graft we have placed. GBR technique, and that is healing. Now have a look at the x-ray, post-op x-ray. Interestingly, we had 4 millimeter there, but because we planned the bone grafting in the same procedure without any additional anesthesia or any surgery, now we have got 10 millimeter of bone present post-operatively. So this is because we have planned the case properly, and we planned it before rather than thinking about the bone loss or the lost bone afterwards. And look at the quality of the bone. Amazing. Nice, fresh, bleeding bone. Grafted, if done properly, the graft should work very well. We did the osteotomy, placed 2 implants, and look at the soft tissue healing. Absolute amazing, hyperkeratinized mucosa all around the implants, and that's the kind of mucosa we want. And have a look at the post-op x-ray. You can see the patient own bone had 8 millimeter implant, but the bone grafted, we did the graft in that area, and that had a 10 longer implant. So think before taking the tooth out, not after taking the tooth out. And that's the post-op picture. You can see that's 5 and 6 that's been restored, and these are the screw retained crowns. Once again, have a look at this patient. Upper right 6, which is quite badly infected. I'm doing well. It seems I've got no messages that we can't hear you, so I'm doing well. So this number 6 is infected, has been root treated twice, and hopeless. But have a look at this floor of the sinus. The moment I'm going to take this tooth out, I'll be in the sinus. And then can I place an implant immediately in here? Can I immediately load it? These are the big, very big questions. For me, I can't. I will say no. You don't have enough height for primary stability. So let's plan this case. Let's do the case slowly, no rush, in a better way. Because we very much knew that the moment we're going to take the tooth out, we will be in the sinus. The oral interfistula is going to be there, or oral intercommunication is going to be there. So we did take the tooth out, removed all that granulation tissue, and you can see, as we mentioned before, the oral intercommunication, it's there. No problems. We will repair it and then later on place an implant in there. So the way we repair these defects are, you can see, very well see, we're peeping into the sinus. The membrane is gone. It's already, because of the infection, it was very, very fragile. So what we do is we place a membrane to replace the sinus membrane, the GBR membrane to replace the sinus. So we have done is we have put the GBR and made it a new floor of the sinus. Put the graft in and then another GBR on top. So it's a sandwich technique, 1 GBR, graft, another GBR on top, and then the closure on top. And that is the post-op x-ray. You can see we've got decent bone in the area where we have taken the tooth out. So the key was that I didn't lose that bone. If I would have lost that bone, there was no way this patient will have a massive lateral window and would have graft later then. But since we saw the tooth with the patient, with the tooth in, we took the tooth out and dealt it there and then. So nice, decent bone. Again, osteotomy. I'm a lover of osteotomes, although the problem with osteotomes is that the patient it can cause discomfort to the patient, but there are magnetic osteotomes or melts available as well now. So with osteotomes, place the implant in, and you can see with the implant, we've done the crestal approach and placed the implant in. So extraction, grafting, crestal approach now, and look at the soft tissue healing. Keratinized mucosa all around, nice abutment in there, and that's the final picture. And that's the final picture and the X-ray. You can see nice bone developing around your implant, and that's your implant in. Once again, another broken tooth. When you've got broken teeth like that, make sure that the way to take these teeth out atraumatically is to divide the tooth, not the bone. So don't touch the bone, but divide the tooth, so that when you remove your tooth, the bone is untouched and is not damaged. So we divide the tooth, took the tooth out, bone grafting done, osteotomy done, and we place the implant in. And look at the keratinized mucosa. So you must have seen this in all the pictures I've shown you just now. The mucosa, the keratinized mucosa, is the same in all pictures. The reason being that if you do not have good bone quality or quantity, you cannot ask the mucosa to be like that. You have to provide the good foundation for the mucosa. And that's the final picture. As dentists, we have to be, we are very good at work, we are very good at drilling, we are very good at hammering, but we need to be minimally invasive for our patients. So think about the ways you can be minimally invasive. You need to know your investigations, you need to know your anatomy, there's no doubt about it. If there is something which is you cannot understand in a CBCT, then get an advice, get it reported, let the radiologist have a look at it, so get an advice from the ENT. So you need to know your diagnosis, your investigations. Likewise, you can see there's a septa which is showing in the CBCT, so you should be aware that what you need to do when you're going to do the sinus lift with the septa. Guided surgery, again, we do quite a lot of guided surgery. It is, again, a minimally invasive way of treating patients in posterior maxilla. So you plan everything on the computer, you plan everything virtually, and then literally on the day of surgery, you follow that planning, you follow the guide which has been provided to you. So this is the patient which we did with guided surgery. You can see we have planned the implant in there. And that's the CBCT of the patient. We're going to take the 5 out. You can see 5 is gone. It's got a periapical radiolucency as well. But with the help of CBCT, we were aware that we will be able to place implant immediately. There will be enough bone around it to place the implant immediately. Not loaded, by the way, only place it. So that's some more views of the CBCT scan that will show you a bit more. That is the green line is showing the intraoral scan, and that has been amalgamated onto the CT scan. So STL file has been amalgamating on DICOM file, and that's how you do the planning for soft tissue and hard tissue for your guided surgeries. And that's the patient. You can see number 5. That's the virtual planning we have done. We place the implant. The dentist need to know the system. The dentist need to know the software. The dentist need to know how to play with it. That is very essential. The implant is planned. The guide is made. We use SMOP guide quite a lot for our patients. The guide is made, and you can see when we took the tooth out, you can see a big gaping hole on the buccal side. So we place the, we know about it because scan showed us. So place the guide, drill through the guide, and we place the implant through that guided surgery, and that's your implant in with the help of guided surgery. Then there is osseodensification, where the bursa bars osteodensify the bone rather than cutting it. So that's another minimally invasive way of treating or improving the quality of bone in posterior maxilla. You can see from this slide that when osseodensification is done, the bone quality is increased in that area. This is a patient we did, and good old internal sinus lift or Kestrel approach is there as well. There is no sort of question to its predictability. This is a patient which the number 6 has to be replaced. So you can see it's got a 0.5 centimeter of bone present. We did the osteotomy, checked the floor of the sinus. Here I'm checking the floor of the sinus is still intact. And then with osteotomes, we break that floor of the sinus, put the graft in, put the implant in, and then that's the closure. That's the final picture of this patient. And that's the result 10-year post-op. So if the things are done properly, predictability is what you can give it to your patients. You can assure your patients that you can do predictability, you can deliver predictability. But I think for that, the planning. We use PRGF as well quite a lot, and that's another way of enhancing soft tissue, I would say. This is a patient which was referred to us. The implant was actually dislodged in the sinus. We had to do lateral window and then lateral grafting and closure with PRGF. These are the references, and these are my email addresses. So please, if you have got any questions, any concerns, or if you want to discuss anything, email me, and I will be happy to help you. And that's it for me. So thank you very much. And I think I'm going to see if I can answer the questions now. Okay, so excellent presentation, excellent presentation, excellent presentation. I think the chat, I'm going through the chat at the moment, so you have to bear with me so I can see what people have been posting on, because I have been hearing the beep throughout. So okay. What did you use for grafting? This is a question from Baba Jamal. Baba Jamal, I use different materials for grafting, and some of the cases you've seen was from xenograft. Some of the cases you've seen was from synthetic graft material. So I don't want to name any graft material because I don't have any, I don't want to make it biased. So, but the key is that all the graft materials are going to work if you do it properly. So my approach is that we shouldn't be blaming the implants, the graft materials. It's us to blame. If the things don't go well, then it's us to blame. So I'm done answering. So Baba Jamal, we've done that. What if we perforate the membrane drilling? If we will perforate the membrane during drilling, it depends what kind of defect we have got. If the defect is smaller, then we can leave it. 2 millimeter defect are left alone and they can be dealt with if the primary closure is intact, if your surgical skills are so good that you have actually achieved primary closure. If the hole is bigger, then one way is that you use the microsurgical instruments and get the hole closed. Or my way is wait. I don't actually have bake rush decisions in my practice. I wait, let it heal, the way I've just told you with the oriental communication I've just shown you. Just graft it and wait. I'm done with answering. Okay, so that's all done. What should be the ICQ for immediate loading? Different implant companies and different have got different recommendations. Different measuring devices have got different recommendations. So I think the best way is to consult the implant company, what ISQ, the standard ISQ, or what the ISQ is, what they recommend for immediate loading or placement or whatever you want to do. But I think that depends on, that is company specific. So I've done with that. Role of PRF in bone grafting, my friend Radna Islam. I think it's more soft tissue rather than bone grafting, and I think you can agree with that. So it's more soft tissue rather than the graft. Angulation of implant for less bone, Shazad Wasim. I think, yeah, you're right. You pointed it well. I think if bone is less, you can tilt the implant palately, but for that you need to think restoratively as well. That if you're gonna restoratively, how you're gonna restore it if you're gonna have too much implant placed on the palatal side. So think about the restoration as well, but you can definitely slightly tilt it palatally. What's your post-follow protocol regarding sinus? It's the standard protocol for sinus, the same nasal decongestion, the same do not blow nose, the same protocol. I don't use anything specific, or I don't have anything specific in instructions, although the instructions are quite thorough and patients are repeatedly given them. So one day if I've given them, my next day my nurse actually calls the patient and delivers the instructions again. So that's, I think, the most important part. The instructions are going to be the same. What's your opinion about autogen harvesting tech comparing graft technique? Peter, always complex questions, Peter. I really don't know the answer, Peter, as I would say, because it's autogen harvesting tech comparing grafting. I'm not really sure what you're talking about here. So you can WhatsApp me. You WhatsApp me all the time, Peter. So I know. Sorry, I really don't know what you're talking about. So I think that's it. I have answered the questions. Let me finally have a look at the chat. Yeah, so it's all, I think I have done that. Let me look at the questions again. Shazad Wasim has asked about short implants. Yeah, they do work as well. You need to decide whether you're gonna do bone grafting, achieve bone height, or you're gonna use short implants. That's your clinical decision. And I would say no one size fits all. It's different techniques, different plans for different situations. So I think the best way is to decide at that time. Yes, short implant work as well. How much angle can we compromise? Shazad, it's really what implant system you're using, because what restorative leeway they are offering you, how much of angulation they're offering you, how much of actually stretch is there in their restorative system. So that actually depends on your implant system. Length and diameter of short implants, again, it's 5 millimeters, 6 millimeter, 5 millimeters, 6 millimeter is the width, 5 millimeters, 6 millimeter is the height. Different implant companies offer different length and widths. Thank you. So I think that's all. So thank you very much for listening, and hopefully you've enjoyed, guys. You have got my, okay, Peter has asked again, do you prefer graft material or autogenic? No, Peter, I actually prefer graft material. Autogenic bone, I always struggle getting the consent from my patients. They do not want a surgical second surgical site, and that's the only struggle I get. So it's always most likely graft for me. Yeah, I do scrape bone around the surgical site. I have got bone scraper, so I do mix it with xenograft, but it's mostly graft material. Thank you very much. Thank you. Okay, that's fine. Thank you very much, and I hope you've enjoyed it and you enjoy the rest of the evening. Thank you very much. Thank you. Bye.